today. So today with us is Luca Ferretti, Dr. Luca Ferretti, and he's a career development fellow of the Pandemic Sciences Institute of the University of Oxford. And Luca has an extensive multidisciplinary experience, an expert in complex systems, genomics, evolution, epidemiology of infection diseases. And indeed, his research revolves around models and methods to analyze and understand the epidemiological and evolutionary dynamics, especially of viral pathogens. Luca is very well known for his work on digital contact tracing during the COVID-19 and beyond. And this has been really important also for advising government later on the use of these technologies and helping everybody with the situation. So I'm really looking forward to your presentation. Luca, welcome to BSc. And yes, the stage is yours.
Thanks so much for having me here. As you can guess, I will talk about digital contact tracing and the developments towards precision epidemiology. Just a couple of words, since I don't know if you know my current institute. The PSI is a new institute from the University of Oxford, essentially collecting all the major developments in terms of pandemic preparedness. The AstraZeneca vaccine that was developed actually in Oxford, the recovery trial, the first clinical trial that actually worked during the pandemic, contact tracing apps, and so on. If you're interested, there's a quite nice conference that it is organized every year. This year is around June. I think abstracts are still open for a week, in case anyone is interested in that. Let's move to the main topic, precision infectious epidemiology. So I don't need to explain to this audience what precision medicine is, for sure. So essentially, we know that everybody is different, and we know that we want to target therapies. In public health, that has a slightly different meaning. If you think about precision public health, that means essentially targeting specific groups, either because of their characteristics, or a lot of the time, because of where they live. So there is a lot of spatial public health, and of course, for vector-borne diseases and so on, there is a lot of spatial analysis and precision analysis that are being done. However, if you think in terms of epidemic or pandemic preparedness, the picture is a bit different. Do you know what this pump is? Alfonso knows very well. This is John Snow's pump. The last time I visited this one was a few months ago. And what is interesting is that essentially, this is the example of classic epidemiology, finding out that all the cases of infectious disease from a certain area came from a common source, and finding out that that source is the origin of the pathogen. That is interesting, and that is some way the whole style epidemiology. But if you look at this picture, most of the interactions nowadays don't revolve around pumps or things like that. They revolve around interactions between humans, and there were lots of people around, moving around. London was packed that day, lots of interactions. And pathogens are very effective at spreading, not so much through pumps or things like that we can stop easily, but through the air. So essentially, most pandemic pathogens or most pathogens with pandemic potential are the ones that are transmitted through the air, droplets, airborne, whatever is the mechanism, but essentially you need the close contact that is frequent enough. And they are really difficult to stop because we cannot stop breathing. And that creates a completely different situation because we don't need to think about who each individual is, what are their features, but we need to talk about their relationship. So who is in contact with whom? What are they doing? What is the kind of interaction that they have? So that brings the perspective from a sort of individual level-based to a network-based perspective. So contacts between humans are important. And of course, there is a temporal aspect. These pathogens spread quite fast. The big difference essentially with the epidemic or pandemic potential is exponential growth. This means that you have to also care about the temporal aspects and all the complexity of the infection process. And this is where there is a field that has not been explored enough. This is precision infectious disease epidemiology. One of the reasons why it hasn't been explored enough is that it's difficult. You have to collect a lot of information about human interactions, and this information should often be pathogen specific. There was an attempt at doing that during COVID. Oh, sorry. Yeah, no problem. Let's see if this works. Okay. So during COVID, there have been two main attempts at going towards precision epidemiology. One, you know it very well, is genomics. Essentially, we sequence the virus like there was no tomorrow. It was basically pointless. I mean, there is little. As a person that has a background in genomics, I'm really sorry to say that there is little that actually came in terms of public health from this kind of sequencing. A little bit was by chance. The variants had a specific marker in the PCR that was able to discriminate between variants all the time. So unfortunately, genomicists found out that essentially all their work was basically pointless in tracking the variants. So beautiful evolutionary biology from my perspective, but unfortunately, in terms of genomics, there's little. Also because we were not ready. For the next pandemic, there are more options, especially in terms of immunology and so on. But I mean, many people in this audience know this part very well. The other part is what I call opportunistic big data. So you have all looked at the Google community mobility trends during the pandemic. What I want to remark is that these are super interesting, but very poor data compared to what Google could have provided. We can discuss separately why the big tech did not want to provide better data, because this was really the minimum. The interesting thing here is that this was opportunistic in the sense that there was no plan before the pandemic to analyze this data. This was not for public health. And in fact, essentially, there is no background, there is no correction for yearly modulation, there is nothing in this data, because essentially it was made up at the beginning of the pandemic. And this is a critical issue because essentially it means that these kind of sources are not really good for epidemiology. Better than nothing during a pandemic, but we don't want to end up with these sources. Now, given this, there was and there's always been a role for digital and participatory approaches to public health. They are not popular in public health for a reason. I mean, public health is a conservative field and people don't want I mean, it's not that they don't want to empower the citizens, but there is some kind of doubt about the extent to which public health should be centralized. But the point is that during a pandemic, given the complexity, given the need to reach as many people as possible and to have interventions at work, involving citizens is essentially the only way to collect data properly. I mean, actually, you can see these Google community trends as a way to collect data from citizens by sharing publicly their anonymized data. But there are many approaches that are more informative in terms of public health. You know, probably rapid testing. I mean, in England, I think between 1.5 billion and 2 billion tests were distributed, an incredible amount. My autumn 2020, instead of working on contact tracing apps, was spent on the authorization to use rapid tests at home. And honestly, I think that may have been a contribution that is more important for the pandemic, at least in the UK, than what I did for contact tracing apps, because these tests were widely used and allowed essentially an immediate isolation of cases, and they acted as a not only as a democratization of public health, but also as a very powerful tool for people to take things into their own hand and to speed up the response. But there are other things that are obvious. One is mobile phones, of course, and the other for the future is wearables. I don't want to offend your intelligence why we're talking about digital, but let me emphasize a couple of things that people tend to forget. Digital is low cost. During the pandemic, and nobody wants to invest in pandemic preparedness, and having something that is low cost, of course, once the technology is there, for example, with smartphones and apps, that is really important because there is no money for pandemic preparedness, even now that we have been just out of the COVID pandemic. The other one is that they are easy to deploy at scale. If you want to push an app to the whole population of Spain, for example, you can do it probably in 2 days, reasonably. And another one is interesting for epidemiology is that they provide high throughput, high quality data. This is not trivial. I mean, there are many other sources of information. For example, manual contact tracing provides very rich data, but the data output has been a mess during the pandemic. it's now many people think that LLMs can solve this issue, and they are probably right. But still, there are many problems about essentially, you have different pieces of data in different local health authorities. So, for example, in Spain, you would have contact tracing data in each of the communities, and they won't talk to each other, as you probably know. I mean, the same in Germany and in every other country. So one of the advantages of having this digital system is that typically you can collect all the data in one place and do the analysis all together. Why mobile health? Again, I don't want to offend your intelligence by going through this. I mean, we have more mobile subscriptions than people in the world, and essentially 60% of these are smartphones, and you can see the growth. So the COVID-19 pandemic was the first real opportunity to use these technologies, and this must be emphasized because of the growth in mobile phone users and essentially the fact that these smartphones are now modern enough. Similar ideas had been floated around mid-2014, 2015, but the coverage was still not sufficient and the technology was not mature enough. During the pandemic, the technology was mature. You know how it ended. I think some of you installed this app. I don't want to go through the history of the Spanish app because I don't know it very well. I mean, and nobody really tells me what went on. So I don't have much to share, and in any case, I wouldn't want to. But starting from the beginning, essentially our point was epidemiological rather than technical. I mean, everybody was like calling us techno-solutionists, but our point was strictly epidemiological. Essentially, you need to be faster, and you need to have effective contact tracing if you want to stop transmissions, because there is too much of asymptomatic transmissions, and classical contact tracing comes with an excessive delay. And that is why we propose digital contact tracing. The idea, as it happens with many good ideas, it comes at the same time in many places. So there were already teams that were putting it together while we were proposing the idea in Singapore and in the US. The idea is quite simple, essentially. You measure proximity with digital tools. So you use the power of digital and those smartphones to detect proximity between individuals. And then you send the automatic notifications using the speed as an advantage. Of course, as I was saying, it's scalable. This is quite important in terms of preparedness, because you want something that is scalable and not limited by epidemic size. Fast, of course, you can send notifications almost immediately. In practice, it's a matter of few hours for technical reasons. Then you can detect, in principle, all contacts provided people install the app. The theoretical basis is quite simple, essentially. When you take Bluetooth low energy, essentially the strength of the signal between two phones is a measure of their proximity. So and this is true for any kind of approach. Now there is ultra wideband that is the new approach, and a mixture of Bluetooth low energy and ultra wideband will be the future. But that doesn't change the fundamental fact that essentially you measure proximity by strength of signal, and you assume that epidemiologically proximity is a proxy for transmission risk. Both these things have been adopted a lot during the pandemic, a lot. I mean, I was surprised how much these two things were actually controversial. A lot because of Bluetooth attenuation and a lot because of airborne transmission and the possible lack of a relation between transmission risk and proximity. We go through this in a moment. There has been a lot of simulation work showing how this could have been effective. Again, some of this comes, Davide, you were not of this one, and I think you try well at least. So I will not go through this, the literature. And there have been, of course, a lot of developments in terms of the deployment of the apps. I mean, overall, I think it was about 82 countries overall and hundreds of millions of users using these apps during the pandemic. All of these, well, not all of these apps, but pretty much almost all were based on Bluetooth Low Energy, and most of them with privacy-preserving implementation. This is important because essentially that meant for many people that they couldn't collect data. There were some apps in Europe that were going around on the phones of millions of users. I think one was in Latvia, and nobody knows who installed it, what they were doing. In principle, they could have sent notification and put people in quarantine like crazy, and nobody knows, which was an extremely curious situation. in terms of epidemiological and public health requirement, it's quite simple. You want to have it integrated. You want people to install it, otherwise it's pointless. There is a network effect. So for the app to work, you need both sides of the interaction to use it, of course. You need to be faster, both in notifying, and you need to quarantine infectious individuals, otherwise it's pointless. And the last point, you need to be able to evaluate the effectiveness, because that's a public health intervention. That was a critical point that people tended to forget, and that's why we had very little data. Painfully learned lesson. It's a public health intervention, and that means, in practice, that only places with strong public health system were able to actually make full use of the app. So if you look at the apps that worked, they needed a public health system that was working. You remember this kind of titles in newspapers, and that's still essential. In many cases, we weren't even able to test rapidly enough. So it was pointless to have these apps if you didn't even have a testing system. Uptake is critical, and the trust, well, you know how much trust has been a problem through the pandemic. There would have been ways, so I mean, people studying business of innovations know of ways to build value. It's the classical Facebook model. You start with Harvard and then you scale up. Government doesn't know about this. Don't ask me why, we can discuss, but this has been a difficult issue. I mean, we pointed out this while most of the apps were being deployed, and it was quite obvious. And but in terms of government, this was difficult to push. Now, I don't want to say anything about the Spain shop, but I can tell you that most contact tracing app deployment were quite ineffective. I take Immune in Italy because I worked on the app, so I can badmouth it because honestly, it's been not because of the app. The app was very successful, but essentially there was no integration between testing and digital tracing, moderate app uptake, and of course there were different parts of the public health system, and nobody was talking to each other, and half of them were not implementing anything. The result was that it was pointless, and in epidemiological terms. And what I know is that many of the same problems were present in Spain. I don't know to which extent, but what I had is that essentially there were many similarities. I go to an example of app that worked and worked in an interesting way. This was the NHS COVID-19 app, not the name of NHS. NHS is a very trusted brand in England, and that was one of the reasons for the success. It was quite successful in terms of reaching a part of the population. 1/3 of the population was not as much as we would have wanted, but still, it's quite a nice number of people. And the big driver was the check-ins. So you need to use this essentially to enter pubs and restaurants. You needed to show to use QR codes, and one of the functions of this app was to use them. People were not so much interested in contact tracing, but of course there was a fraction of people who just were installing the app because of check-ins, and then they were using it. So giving value, so unsurprisingly, giving value to the user is one of the good way to push these apps. Or gamification in modern terms, one would say. But convincing a public health system to do gamification is difficult. So this was the best. And what is quite impressive is that this was, in terms of the part of the population that you could reach that would actively engage in public health, because of course there's a part of the population that will never engage. But in terms of those who would engage, for example, those who would get tested, you see, because in England, tests were not compulsory for a long time. And you see that of those who would get tested, the app was able to get almost 2/3 of all positive tests nationally. So essentially, in terms of the part of the population that would actively engage with public health, we were getting the majority of it, which was quite good. One interesting thing is scalability. Manual contact tracing, that is a classical alternative, has a problem of scalability. I don't go through the math because you can imagine it. You have a finite pool of tracers. You have an epidemic that goes exponential. At some point, there is a tipping point where you cannot control it because essentially you don't have enough tracers, and then of course there is a super exponential effect because you have lost the track of the. So contact tracing doesn't work anymore to keep the epidemic controlled, and you have to increase even faster. I mean, this has been one publication by a group of physicists that was very nice in this respect. One of the first ones surprised. I mean, it's something obvious for physicists and quantitative people. It was something not obvious to public health people. What is interesting is that, of course, you can see that manual tracing is not scalable, but digital one is. So if you look at this plot, you can see that the waves correspond to periods where manual tracing is actually performing less than usual. It can find less contacts than usual. Why? Because it's overwhelmed. So the number of contacts per case is lower. While you see that the waves, unsurprisingly, correspond to peaks in the number of contacts that are per case that are detected by the app. Of course, because the app essentially can scale no matter what, no matter what is the size of the epidemic. It scales very well. This is interesting. I will skip, I think, all this. I will briefly show you the impact of the app. So you can see that in terms of local areas, they are called lower tier local authorities. So there are about 300 of this kind of local areas in England. And you can see that across these local areas, there is a wide difference in app uptake from almost 40% to less than the 15%. And you can see visually, if you look at the epidemic curves, that the areas that had the highest uptake of the app had by far the lower epidemic curves. Now, this is, of course, is not because of the app. It's because of a lot of confounders as well. So it's nice to see that, but the problem is that in public health, essentially, there are all kind of correlations and all kind of heterogeneities. So it's very difficult to convince people that this is effective. And actually, it was very difficult even to convince ourselves what was the right way to evaluate effectiveness. So we went for two different approaches, completely independent in terms of data and in terms of method, thinking that if we would have got the same ballpark estimates, that would have been reliable. The first one was to model the cascade that was giving that was in the end avoiding infections. That is essentially you have to send the exposure notification to individuals. And of course, you have to send them to the individuals who are infected, because the ones who are not infected are not stopping any transmission. You have to assess how effective was the intervention in terms of isolating the individuals. You have to prevent transmissions soon enough. If you send a notification too late, that's pointless. And then you have to consider if you avert one, since you are in an exponential expanding phase, if you avert one case, how many cases are averted along the line? So the whole chain of transmission can be much bigger than that. So essentially, you have to put together all these estimates. I won't enter the details, but essentially, we had enough data analytics to estimate everything but this number. That was estimating how effective is something. It's incredibly difficult. There were estimates that were going from 10% to 60% to 90% from surveys. So all the rest is from the analytics of the app, but this part is a really difficult one and with wide uncertainties. Our central estimate was about 300,000 cases averted in autumn 2020. Or if you want, for each % increase in app use in the population, you would avert 0.8% of cases. Then we use a completely independent approach, a regression-based approach, following some work by Miguel Hernan, where the idea was precisely to use big data. I mean, we couldn't do a really randomized control trial because of ethical reasons. You cannot just decide, oh, in the middle of an epidemic, I deploy an intervention here, but not here. That would not be ethical and nobody would approve it, unfortunately. That would be the best. But you can use essentially the fact that at random, people have different uptakes in different areas to try to disentangle what is the effect of the app. And the idea was essentially that we were taking local areas that had the same initial state of the epidemic, pretty much, the same quintile of the cases in phases before the app was deployed, and looking at the difference between local areas that were adjacent and with the same number of cases, and see if the app uptake, once you correct for poverty, rural urban nature of the area, or local GDP, was still significant. This was one of the 10 analyses that we did to make sure that this was robust, but this was the most conservative analysis. That's why we showed it. And our estimate is that essentially number of cases averted was about 600,000. Or if you want for each % reduction in, sorry, for each % increase in app usage, you would reduce a bit more than 2% of cases, which is, these numbers are not bad, because if you, if you consider a ballpark of 500,000 cases averted, in the same period, the number of cases was 1.9 million. So we're talking about relatively big numbers. Given the epidemic was spreading essentially, even if the app had a small effect, overall the numbers were quite large. And it's showing that essentially, given the large uncertainties, the ballpark is the same. We gave some random estimates of the total number, because at some point you discover that these approaches break down, essentially. When you start introducing vaccinations and other confounders, these approaches break down. We gave a very conservative estimate of a total of 1 million individuals, but I don't believe this estimate, to be honest, for several reasons we can discuss. So the numbers are probably larger. Don't ask me by how much. And very heterogeneous, of course, geographically. Now, all this is interesting, but going back to the original point, this shows that the app had an impact, but not that the impact was caused by contact tracing. So now we want to find out if actually the app was actually measuring what it was supposed to measure. Now, the app internally was using a risk score, essentially was assessing each contact by several pieces of information. There were 3 main components. Proximity, so how close were 2 individuals according to the Bluetooth signal. Duration, how long was the encounter, and the infectiousness, which in theory should have been some information about the distribution of infectiousness with respect to the time of onset of symptoms. In practice, when you have to work with public health systems, the NHS told us that we couldn't use anything that was, the NHS and Google and Apple put, say different constraints that made it impossible to use this information. So infectiousness is sort of a 0-1, a few days around symptoms, let's say, while duration and proximity are fully taken into account. Other apps were able to detect infectiousness, and you see that there is the smooth curve that you expect and so on, but our didn't. We had an anonymous app analytics. The reason for this analytics is interesting. It was not for public health. It was because the Information Commissioner's Office told us that it was not possible to have an intervention that was public health on millions of users without having a strong analytics that would make sure that the intervention was actually working correctly. This was something that should have been obvious for all European apps, but wasn't. And I think the Council of Europe decided that, but much later in the pandemic, that this should be the standard for every future app, unsurprisingly. Now, I'm focusing on a period that is the high quality period, which is about 1 year, around 2021, 2022, early 2022, where we were able to essentially reconstruct 7 million contacts for a total of 23 million hours of exposure. So most of the results will look at this period. First, we want to see if we were getting something. So if we were taking the maximum risk score that the app was detecting, that was essentially distance and duration for the most risky window that we could find. What is the empirical probability of reporting a positive test afterward? We would expect a monotonic relation if the app would work, and that is what we get. So in this sense, the app worked properly by predicting positive tests. We can do more. We can try to assess transmission risk. So we can try to measure transmission risk per half-an-hour window, which was the classical exposure window. For technical reason, all our data were cut in this window. So during a 30-minute exposure window, we can try to estimate statistically the risk due to that interaction specifically. The risk was essentially proximity times duration of exposure. And if this would work, we would expect a straight line. It's not so bad. Honestly, I was, given that the risk function with respect to distance was made up by me, Chris, and Christoph at the beginning of the pandemic, after talking to a lot of experts and finding out that nobody had an idea. So this is also actually better than what I was expecting. So actually, contact tracing apps can assess transmission risk quite well. So all the issues about Bluetooth and so on, yes, there is noise, there are a lot of things, but on average, you can assess transmission risk quite well. This opens a very interesting possibility, however. Opens the possibility of using these tools for epidemiological measurements. And here is where a lot of the new interest lies. Because essentially, we have a problem that we don't measure things well enough for pathogens. We don't have tools for precision infectious disease epidemiology usually. And these apps represent one such tools. First, we can look at something that has not been done before to this resolution and not even closer. What is the risk by proximity? So different colors are different levels of proximity. Don't ask me why it's not in meters. Take it as a score. It's a score that should represent something like the risk. So 4 should be twice as much as the risk as 2. We can discuss why it's not in meter, and it's a bit complicated, let's say. And then you can measure it against the hours of exposure. And what you see quite clearly and quite nicely is that essentially, of course, there is an effect of proximity. So of course, so if you take an exposure of 1 hour, you go from 0.5% to about 2% in terms of risk. So depending if you are closer or less close, I mean, of course, proximity matters. This is something that we sort of expected. It was basic. But duration matters much more. This curve is in log scale, and the initial part is almost linear until about 3 hours, and then slows down. So this is also what you would expect. You would expect that staying together for 15 minutes and staying together for 15 hours should be different. But this is something that public health experts were not considering to that extent, and essentially was never a big part of the communication. And yet duration is the most important determinant. I mean, in some sense it's trivial, in some sense it was completely unexpected, in a sense it was not what most people would have estimated. Consider also that the numbers are small. Again, this is something that if you try to do the math and you try to write the model, you expect something in the ballpark of 1% risk per hour. That's fine. But people were not doing this back calculation. 1% risk per hour is much less than most people would have guessed for COVID-19. And also meant that main intervention could have been calibrated better. All this is interesting, but it doesn't matter that much, because to calibrate intervention to understand what's going on, you don't need to measure these quantities for individual contacts. You need to measure how these things are distributed in the population. These are the distributions of the closest proximity of contacts and the duration of transmissions, of exposure, sorry. So on the left is essentially the closest proximity in terms of some score, and on the right is the duration of exposure. The blue curves show the distribution in the population. And these distributions are highly left skewed, as you would expect. Essentially, we have a few very proximal contacts and many contacts far away. The duration of exposure is a bit different. It's also very less skewed, but you see that there is a bump between 10 and 50 hours. That correspond to workplace and mostly household interactions, as you would expect. So we tend to have some intense interaction that lasts for a long time. The interesting is that you can look at what happens if we look how transmissions are distributed. You see that both in terms of proximity and in terms of duration, transmissions cover a wide range of parameters. So basically, the contribution of contacts of 50 hours and the contribution of contacts of half an hour is pretty much the same. And all the range in the middle is quite uniform. There are 2 sort of peaks, but the whole range is relatively uniform. This means that essentially ATI, or if you want transmissions, come from a whole range of durations, and then cutting down these transmissions is tricky, because essentially you have a large contribution even from very large from very long contacts, but you have also a lot of contribution from short contacts, and it's very interesting to ask what would happen if we would prolong this curve on the left side, but I don't want to go there. We can discuss later if you're interested. Implications, if you try to use the app data in smart ways, essentially, unfortunately, we don't have the hour of exposure. I mean, we would have loved to have the hour of exposure and to know how many of these were doing lunches, how many of these were when people were meeting on Saturdays and so on. We don't have all these, but we were able to use the amount of exposure during the day in a relatively smart way to separate households from people that you meet multiple days. so frequent contacts, most likely workplaces or relatives and so on. Single days and the fleeting ones that were less than 30 minutes for us. You see that in terms of contacts, most of the people that you meet are from less than 30 minutes. And then just a small part, less than 25%, is from habitual contacts or households. But if you look at duration or at risk that are highly correlated, as you expect, then it's the opposite. Households accumulate most of the duration and most of the risk, and the risk of fleeting contacts is almost negligible. And of course, this gets reflected into transmissions. Most transmission, well, 40% of transmission come from household, 25% from these recurring contacts, and relatively little from fleeting contacts. I should say we have limitations in detecting very, very short contacts, and I'm not sure what happens for that part. So this is for detectable contacts. We can discuss separately about undetectable ones. We are working on that, but it's complicated. This has immediate implications for policies. So the first one is, from now on, I would hope that contact tracing would be based on duration of exposure rather than proximity. I'm not sure, because I think even the last WHO guidelines that just came out don't include this, and this is something that is hard to transmit to public health practitioners. The other one is that, of course, we want, so if we can have high quality information, we want more focused interventions. So something like low risk versus high risk contact is too simplified. At least you should have a sort of traffic light system with low risk, medium risk, and high risk contacts. I would argue for something even more complicated, but public health people like simplicity. So more than 3 levels is too much for them. But this would have been a no-brainer. And if we would have implemented this in the optimal way, and of course you can reconstruct the optimal way from the data. So this is the optimal way, essentially, if you would move from a threshold that is based on the duration to a double threshold based on with a traffic light system. No matter basically what is your decision on how much to cut, you gain about 40% in terms of effectiveness, or you reduce your cost about 40%. So actually, precision interventions can have a large impact on the effectiveness and on the cost of the intervention. This is the direction where we want to go. We want to be able to design public health simulations for the future, interventions that are powerful in this respect. I mean, when you think about the cost of the pandemic, this is the bare minimum that we should do. Then there is an interesting part, that is the fact that we can also track things in time and space. And for the way digital contact tracing works, we have a really high resolution, and we can monitor things in real time. In terms of high resolution, what I'm showing you here is the contacts day per day by the day they occurred in England and Wales during 2021 and so on. So you see that there is a lot of structure, daily peaks, lots of weekly effects. And of course, you have a lot of information, because you can also estimate the mean risk score of these contacts. You see that there tend to be a lot of yellow on Saturday. Saturdays tend to be the peaks, the weekly peaks. And there is a lot of yellow because on Saturday you have more contacts, but you have also less risky contacts. You meet people, you meet a lot of people for very short times in very random situations, friends and so on. So this is the kind of resolution. I mean, usually you get a much, you have seen the curve, the usual curves. You get a much less detailed resolution. What is interesting is that you can do the same for transmissions, because you can detect transmission based on the fact that people report positive tests on the app. So you can get the transmissions day by day. And this is our measurements of transmissions day by day after a little bit of statistical reconstruction to avoid background transmissions. So of course, some people will get infected, but not from the interaction that you are measuring. So you have to remove that component from the data, and that is quite tricky. But essentially, apart from that, this is essentially the result of the statistical reconstruction. And you see that there is a quite peaked structure. There are weekly effects. There are other peaks in different periods. And we can also separate, of course, for different types of exposure. So for example, households or recurring exposures or workplaces. So for example, you see a big peak in household exposures, of course, in that period around end of December. You can guess what it is. Come on. Of course, that's Christmas. If you look at recurring exposure, it's interesting because it's not only Christmas. Actually, it's not Christmas is not the big peak. The big peak is the day before. Yes. The Christmas period is one of the biggest spreaders of infectious diseases. Huge. You see all the week, all the Saturdays, the variety is the Saturdays. That is a huge contribution. If you look at single day exposure or fleeting exposure, of course, you see Christmas shopping even more. You see the high peaks for the Christmas in early December where everybody goes out. I mean, it's like crazy. But you see also this series of peaks here in June, July 2021. You remember what it was? So let me show you these on the top of the matches of the Euros. This was the first match of England against Croatia, Scotland, Czech Republic, Germany, and you see that it starts going up. Ukraine, Denmark, and finally Italy. We won the final, but England reached the final, and this was the biggest transmission event in a single day in the whole of the UK epidemic, as far as we know. We never measured a daily peak that was as crazy as that one. We had a fight with science about what to put in the cover because they wanted to put, of course, Wembley and all the people. What happened was not that, of course. What happened was that there were lots of people gathering in homes and pubs and screaming like crazy and drinking and so on. So unfortunately, the cover is a bit misleading because it was really decentralized social gatherings that mattered. England was a bit an outlier in this, probably because we reached the finals. There was a correlational study that said that England was probably the place where this happened the most. The interesting thing from app data is that you can go the next level in terms of understanding what's going on. So here I'm determining the signal because there was exponential growth, there were day of the week effects. So I'm determining completely the signal and showing you the infection events, the continuous line. It is essentially in log scale is the sum of the probability of infection per contact and the contact events. So I'm decoupling what is the number of contacts that you have and what is the probability to transmit the virus. And if you look at the matches, you can see that some trends emerge. In most matches, the big boost in infection is a combination both of having many more contacts and of having riskier contacts because you were spending more time with people and on risky activities, typically drinking, social drinking, you know how England goes. And of course, you could go to the next level and start decoupling the effect of distance and duration and so on. At some point, my co-author in this paper told me, Luca, stop because we have too much material and we don't want to go further. But you could go quite further in this in terms of understanding literally what was happening every day in terms of different interactions. The interesting thing is this peak, for example. This peak doesn't correspond to an England match. And this peak corresponds to an excess in contacts, the peak in the middle, but no boost in. So there were many contacts, but people were not partying. The reason is that this was not an England match. This was the last match of Wales. Wales made it to the made to the rounds and then encountered Denmark and got eliminated. So this is English people watching Wales, not particularly excited, not drinking and shouting like usual. So the probability of transmission is actually standard, but the number of contacts, people went together towards the match. It's interesting because we can separately look at Wales, and you can see Wales is much more noisy because we have much less data, but you can see the matches. And you can see that after they got eliminated, they were watching all the England matches. So you can see the 4 peaks here. They correspond to the last 4 matches of England. But you see the interest was declining dramatically, and so the epidemic, essentially. I won't explain what RT is, you know. The interesting thing is that essentially RT can be microscopically explained by the number of contacts and the probability of transmission as a product. And this means that essentially, since we can measure the number of contacts and the probability of transmission to the app, we were able during the pandemic, and we did this in real time, we gave weekly report to the government, what was a sort of proxy for RT every week. So these were the kind of things that we were reporting every week to the government. For me, what's interesting scientifically, much more than the euros, is the fact that you can do the opposite. So once you have RT, you can decompose it. For example, you can take everything against the typical RT, and you can decompose RT in the contribution of contacts and transmissions. So if you seek any kind of change in the epidemic, you know what you can attribute it to. So for example, here there was one reopening event after lockdown in England, which caused a crazy increase in RT. And if you look here, the increase was partly due to a little bit more transmissibility, due to more intense contacts, but especially to a crazy increase in contacts. Essentially, people were tired of the lockdown and went together like crazy. So everybody was expecting all these changes to be gradual, but it was not like that. There was a dramatic change here, driven by people who wanted to meet again after the pandemic. And if you look here, this is Christmas. You see that there is a double contribution. There is the Christmas shopping. On the top, there is an increase in transmissibility, a huge one. This is because this is when Omicron arrived. So you see the combined effect of Christmas shopping and Omicron that created a perfect storm by arriving at the same time. Let me take 5 minutes to discuss about the future, because I think this was essentially the past, but I think it's important to start thinking about the future of infectious epidemiology in precision terms. Going back here, essentially, I think it's clear that we have to think about monitoring these interactions, and this is not something that is easy, but it's something that is needed for the next pandemic. If you look at the NHS contact tracing app, you see that there were actually lots of functions. It was symptom tracking, there were the possibility to ask for tests, there were check-ins. This was an embryo of what I would call a digital pandemic toolkit. And this is one of the directions where I think we should go in terms of preparedness. There have been several cases for building these in terms of trying to collect all the data that we can from these different sources, mostly smartphone wearables and lots of public health data, plus genomics and so on, trying to put it together and essentially to be able to predict and inform a pandemic response and to feedback this to citizens in order to empower them for the pandemic response. And this is what we are currently thinking in terms of writing a blueprint for digital pandemic preparedness, essentially integrating all these signals from wearable symptom tracking and mobility, and then providing information both to public health, to individuals, and possibly to support in terms of remote health and social support, which is something that it probably will be more and more important in future pandemics. There is another thing that so the point is that this is something that we are pushing. Governments are sort of not buying it that much because nobody wants to invest. So it's possible. There are a few governments that are moving in this direction, but not that many. Unfortunately, because it's actually really cheap. In terms of collecting data, meanwhile, we have to start experimenting. You know, and maybe you have even played the outbreak exercises and games. And you can gamify epidemics. And this is essentially one way to collect things during peacetime. So we are collaborating with a group from MIT. Essentially, Padis Sabeti was the initiator of all this, and now Andres Coluba is pushing it. This is an app that essentially gamifies the whole epidemic process in terms of having essentially having an epidemic game on your phone and using Bluetooth both to measure contacts and to spread the virus to the phones. And you have the full gamification of the experience. If you're curious about running one at the BSc, I'd be very happy to ask Andres. No, I mean, it's an interesting experience. So very happy to have Andres come here. And I mean, we had them at PSI last year, the PSI conference, and we will have one this year. And you find out that essentially calibrating this kind of simulations is really difficult because you have to choose the pathogen parameters beforehand. They chose it for measles, and they found out that essentially the whole conference got infected in like one morning. So yeah, no, but you can detect all interactions, you can study them and so on. Where we want to go is to be able to monitor interactions in real time in a series of contexts. I mean, this has been used for schools, but where I would really like to see it is workplaces, essentially. I would like to push it to workplaces in terms of epidemic preparedness for workplaces. And we would like to get more and more of these networks. This is like, I think, the biggest network that exists until now from Singapore. This work from Rachel Pung and Adam Kucharski. And this is still relatively small. We're talking about 1,000 nodes. It's a far cry from the usual size, and this is cruise ships, so a very particular environment. So where we go from there, what we have is essentially small-scale data or fragmented data, and as you can imagine, everybody wants to use artificial intelligence to solve this issue. I don't know if you have seen this paper. If you have not seen it, it's been published 2 days ago, so I would forgive you for not seeing it. Moritz, also from the PSI, is leading it, and several people that you know very well. The idea was to map essentially what can be done with AI in this field. And I will not go into everything, but essentially one central part is to use AI to integrate a lot of heterogeneous sources of data in terms of what we would call precision epidemiology, and try to use, for example, graph neural networks and more complicated structures to do all we need in terms of pandemic preparedness. So the future is probably to try to collect as many heterogeneous data as we can. Precision data, because I mean, if you don't have the right data, you cannot do all this stuff. There's no way you can. And then design precision intervention based on that. But this needs high quality data. I mean, if you don't have the information about the interactions between humans, there is only so much that you can do, right? If you have a coarse-grained solution. And there is a lot of information that can be extracted if we start measuring networks. Many of these are temporal networks. Well, I'm waiting for the moment, maybe soon it will arrive. Let's see. I'm waiting for this since 1 year and a half. I'm not so sure when it will arrive. But there are temporal networks there. You can literally measure the contacts in time. And I would love to know what was the impact of lunches together, for example. I would love to know. Nobody knows. And it's possible to study it with temporal networks. And there are lots of these contacts that are essentially cliques. And this introduces the fact that they're super spreading, they're hypergraphs in this game. And we don't understand how this plays out actually in real time because we don't have the data. This network that you see here is a temporal network. So Rachel and Adam did the temporal network analysis, and that was really interesting. But again, this is sort of a silly example. What we want is real life, is workplaces, and so on. And all these, the final reason for all this is to feed the precision epidemiology from simulations. So we really want to be able to simulate agents, possibly even agents that are able to take decisions. I mean, now LLM would empower for the first time this possibility to have agents that are able to take decision and to simulate on the top realistic dynamics in terms of human interactions, in terms of time and the way people spend together. And that is, I think, the final goal of where we want to go. We want to have this kind of simulation, possibly essentially having a sort of epidemic digital twin as much as possible, and as much accurate as possible at a small scale to be able to find out which interactions are optimal, which interventions are optimal, how to intervene in details in these systems, and essentially, for the future, this will be the key tool for epidemic preparedness, essentially. And there are challenges on the way, but I think in a few years we will get there. If the interest for epidemics stays a little bit more to a decent level and doesn't disappear, we will get there, I think, in a few years. Thank you very much.
It was it has been really nice. Okay, time for questions.
Thank you for the presentation. It was very interesting, especially for I'm like a football fan. I was really focused in the Euro presentation, and I would like to focus on this part. I don't know if you can back up to the slides, especially the ones of the increasing number of cases.
Which one?
That one. I would like to ask you if during the analysis they do of the increasing outbreak of the increase of the number of cases during the Euros, if they have into account that being that year of the Euros, there were like different stadiums had the different matches and they were not like in the same country, for example, as in Germany, and being the final in England, if they take into account all the tourism and all the different people of different countries that went into there, because I don't know if only they reference the number of English cases and they don't have to account the tourists that also were infected.
So this is only for the English cases. And I think it's quite difficult since essentially we have it only for England and Wales. So we have England, you have seen England and Wales separately. And you can see that they have a different dynamics. But in terms of the number of cases, I think there is surely an effect. I mean, in general, a big effect of these events is on international mobility. So essentially, these matches can spread the virus across different areas. But in this case, the big peak is probably caused by, at least we think, given the numbers, that it cannot be caused by the stadium. And actually, some of these matches were not even in England. So because this Euro was the one that was pan-European, so matches all across Europe. So essentially, most of these cases were caused probably by interactions in pubs and restaurants and in houses where groups of friends were coming together. I don't think it's possible to do much from this analysis in terms of understanding how much came from the stadium and how much didn't. But we have another analysis planned where we want to look at the Premier League, because we have, of course, you can look geographically at the Premier League, how cases are spread, and the Premier League as a natural randomization in terms of people playing in their home stadium or in another stadium. And you can essentially run a combination of this kind of modeling and regression-based modeling to find out what is the risk of a match in terms of pubs and houses, and what is the risk of the stadium actually. So that would be possible with the Premier League data. And I mean, I'm hoping to do this analysis at some point where my to-do list on these things is a bit long. So if you're interested in participating, just get in touch, because there is the possibility of doing that. And actually, this is also, so we don't have many information about which kind of gathering as a given risk. Everybody talks about gathering in terms of size, but in terms of the intrinsic risk, we don't have much information. It's possible the stadiums are not as risky as people think, while the pubs are much riskier because of closer interactions. So I think it would be really interesting to understand if there is a big sport event, what is the actual risk and where it comes from.
Maybe a kind of similar question, but do you think related to this risk of these tourists or from other countries coming in for big events like this, I think for future pandemic preparedness, there's any appetite in Europe for kind of a limited data sharing maybe between countries? Just kind of some sort of index that these countries could get about. Maybe there are like disease vectors coming in, going out.
So one critical thing is that contact tracing data are seen as highly critical and highly sensitive, because the app is a bit an exception, but usually they're identifiable. And second, because they tell a lot about contacts in one region. And third, because it's new data and nobody understands what people could do with that. As a result, data access is almost impossible, both for manual contact tracing. So there are countries like Germany who could have run impressive analysis of manual contact tracing because they had both the scale and the contact tracing platforms to pull together all the data and do an amazing analysis. And they never did because the data belongs to the local health authority, to the lender technically, and no lender wants to share with any other. No way. So even internally within countries, this is almost a no-go. I won't tell you the situation of this data, but essentially none of this data is public. We have pushed for years to make at least a part of the data public. I think at some point we are going to win this battle and make a part of this data public, but it's very limited data. Nobody wants really to share. Even at an international level, WHO hub in Berlin has tried essential. I mean, they don't even pretend that they are going to convince countries to share. They're just saying, we will show the power of sharing data so that people will get convinced to share. Good luck. I mean, I admire their ideas, but I think definitely if you don't push or if you don't put in writing in some, for example, pandemic convenium across countries that you have to share data. Even in Europe, unfortunately, I don't see that that happening so much. Of course, one thing is maybe if we would have digital tools, that makes it a bit easier to share the data because essentially at a national level, for example, in the UK, data was collected all together. Same in Germany, because essentially you couldn't split the data across the land. So essentially, already at the national level, you have data that are together and they are quite comparable. So there would be the possibility. I mean, in Europe, if there will be a step towards epidemic preparedness in Europe, I expect that at least some limited sharing of digital data could be possible. But again, it's tricky, politically tricky.
I would be more positive about, I think that in Spain, certainly, but also in other European countries, the perception of the health authorities of the need of sharing data has changed completely. So in Spain, the pandemic was a disaster. It's absolutely impossible, not even regions, hospitals. Now all the 17 communities are working together with health minister to build the platform for sharing data. They are doing this actually on their own will, so it's not really forced to. And Germany is a good example. Germany was impossible to imagine a personalized medicine project that would share data across the society, and now they are doing it. So I don't know so much for pandemics, but in general for medical data sharing, the pandemic has been fundamental in the European health data space. It's so impossible because there was after the pandemic.
I agree with this. I am still on the fence, let's say, because I want to see how much of no, especially like there are different kinds of data, and quite often the point that if you want to do really high quality analysis, you have to share granular data. That's the problem, I think. Everybody is happy to share aggregated data to some level, but when you're going to share granular data to understand, for example, transmission events and so on, there is where there is an issue. Now, there could be ways around it. There could be federated learning and so much. I mean, I'm not saying that there won't be ways to do it.
I can share the pessimistic. In Norway, had changed the law a few weeks ago to be able to share data between hospitals. Inside the country was impossible before. So I think there are things are moving.
Things are moving. I agree on this. Definitely, definitely things are moving. My expectation is that we will go towards federated learning and something like that. That is what at the European. I mean, within Europe, but we will not able to do anything outside Europe right now. I think that is the perspective. Within Europe, I think there are possibilities. Yes.
Yeah, a couple of good questions. Well, thanks for the talk. The first one was in the heterogeneity of the uptake rates that you showed. Was this related to different geographical areas of the UK? Like I would expect London and the Midlands to be different in uptake.
Yes. I don't have the rated plot, but I have the plot of the reduction in cases due to the app, and you can see that it's quite variable. So you can see that there was quite a lot of reduction southwest, mid and southeast, with the exception of central London. There were gaps. So the countryside was quite okay, but some parts of the countryside were not. Some major cities were not. Depending on gaps of so there were ethnic determinants. So for example, some ethnic groups were buying the app, some ethnic groups were not buying the app. Some rural areas, depending on the GDP. So there are poorer rural areas and there are richer rural areas, and they have quite different dynamics, quite different politics. London is a whole game in itself, and everything we observe in London, I haven't shown London, but everything we observe in London is different. Overall, the major determinants were anyway the one to expect: poverty, ethnic groups, and to some extent trust in government and the rural-urban variation. So I mean, there was a lot of social aspects of this. I mean, the problem is that, so it would have been possible to do better probably, but there was also, so there's been also so there's been a good communication campaign from the government, but a very bad media campaign against the app. Essentially, everybody was convinced that the app didn't work until we got to the pandemic, where essentially there, at some point, all of a sudden, 3-4% of the England population was put in quarantine. So around here, this peak essentially because of the manual plus digital contact tracing plus schools plus other things. I think essentially that week there were maybe 3-4% of the English population in quarantine, yeah, something like that. And since they were the people that were most public facing, essentially supermarkets were not working, public services were not working, because essentially everybody who had a front facing job was getting pinged. And then all of a sudden people realized that the app was working and they asked to shut it down. So we had a very bad media attention until here, and then all of a sudden everybody was like, "Oh, but the app is working too much. Please turn it off." It's getting the right trust is not easy. This is a problem for the future.
My second question is kind of, so for example, UK is also famous for having like a lot of CCTV cameras. That maybe, like, is this something for the future where you're talking about like different integration, something that, from the government side, like, could be used, or is it like stepping into, I don't know, a bit of surveillance issues with the population, and then, doing all this trust you earn by using this kind of
so you can use them to monitor essentially density, and that is what's done essentially to monitor densities in open environments. But if you think about matching individuals through CCTV cameras, then so I think anonymized analyses are fine as soon as you move towards recognition. I mean, maybe we will move there anyway because of police efforts, and then the whole thing becomes a bit moot. But the truth is that I don't know if there is much appetite for that in public health. Also, I don't know if it's so useful, because I mean, what I would see as a priority would be essentially pushing for several tech companies to share data more actively and more proactively. I mean, honestly, rather than convince citizens to share the data through cameras, that is a bit fishy, I would like anonymized paths, for example, from Google Mobility. That is a very low-cost thing for governments. The point is that tech companies have been unwilling to go in that direction. But I think that is one direction where, now the exception is mobile companies. So tracking mobile phones through cell towers, that is something that, as you know very well, there's solution. Not for precision interventions. I mean, if you want a special scale, okay, but if you want to see how people interact, no, that's not.
I will discuss it later with you, but do you know why? So tech companies are not willing to contribute. So
in general, this data is seen as a political hot potato. Both from the private sector and for politicians have got scalded by all the story contact tracing apps. But even before that, as far as I know, essentially tech companies were like not willing to enter into the political hot potato of tracking contacts. So because it's a
but the kind of data we were releasing was almost useless. I agree that it's there nothing, but
I agree.
Why they were so reluctant to do this? Is it because I don't know, it's valuable data and it's too weak to follow it? So,
I don't think it's because it's valuable data. I think it's because so many of these companies are built on the idea of privacy. Apple, for example, is built on that idea. So for them, letting people know that they could track a little bit more than that was sort of a no-go.
You think they don't want people to get scared?
because people is already using, people has already agreed on.
Yeah, of
on
course,
the
of course.
use of the app.
Of course, but they don't want to enter that
To wake
field.
up people that they are
Yeah.
actually willing to know the
Because
data.
it's different to know all the data about you, and it's different about if you know all the data about who you are meeting. It's the next level of surveillance for them, and everybody knows
There are
that.
so many ways of releasing data in a way that you are not.
I agree, but and governments could and should.
You know, I don't know. You can.
I think governments could and should knock at their doors and ask them to contribute to pandemic preparedness in that way. But until governments stop at this point, I should also say epidemiologists often don't understand the value of this data. And if you don't convince epidemiologists to push from the government, then the government will not push. So that is the other problem. I mean, I had many epidemiologists, many very good ones that were like, we are happy to do simple analysis on small data sets because we have always done like that and we are happy with that. So the epidemiologists are so,
We got the same.
These people were from Imperial who essentially they take any data set that they can put their hands off on and build beautiful MCMCs essentially to get random stuff because I never know how much to trust what comes out of that. But it's always small data sets and a lot of math on the top rather than trying to go for ambitious data, really big data. That is. I agree, but people were not convinced, and I think many epidemiologists didn't even realize how much you can do with scale. So it's a bit paradoxical, I understand, but
one point about this, like to make those digital tools like more appealing also for the public health. Do you think that maybe like this can also be like this kind of technologies can also be used like beyond infectious diseases epidemiology? Think of all those conditions in which you need like an immediate intervention, stroke, heart infarction, or even the elderly, that you need maybe to monitor with some smartwatches and stuff. So you can alert like people that are around, and then so this with all the benefits, for the public health, like together with the applications in infectious disease.
I think so, and I think there is a bigger argument to be had to integrate these things as much as possible into a smart city framework to be able to use them in peacetime. Basically, you want them dormant in peacetime in terms of classical contact tracing, but active for essentially other purposes. And there is a lot of potential for these technologies. The point is essentially once you get to the point that you convince people to start preparing for that, then it's quite easy to envisage an integration into a more smart city framework. And yeah, I don't expect these technologies to be necessarily useful only in epidemics. Actually, I think there are lots of contexts where you want to know this kind of interactions anyway, and for planning purposes, for example, or to use in other active ways. I mean that would be quite natural, and I think one direction where we will go will be actually not designing public health specific apps, but more like emergencies apps for public emergencies. So integrating different components from fire, earthquakes, public health in general. Yeah. I think that's the direction where slowly people are going. Yeah.
The problem with the Spanish app, for the technical problems, was a lot of strong disinformation campaign, and that's going to be getting worse.
But I think that problem is a problem that you face. So at this point, I think that is a problem that you face in general, so not only with the apps. I showed you that essentially there was a big overlapping between people who were choosing to get tested and people who were actually using the app. So essentially, in terms of the people who would actually contribute to public health, the apps were doing quite, at least the English app was doing quite well. The point is that there is a part of the population, is not a small part, is not engaging, was not trusting, and now the problem has become twice as bad compared to the pre-pandemic. I think we have probably to accept that all kind of interventions will have this problem. I mean, for me, this is not necessary reason to stop using these tools. Actually, it's a reason to push them anyway, because there is a part of the population is actually very willing to use these tools. I mean, the amazing thing is that, so I haven't shown it you, but in terms of uptake, we got, so this is the peak around this pandemic. Then around here, essentially the app was officially discontinued, but actually was stayed on. And you see that we kept having users until the very end when it was actually shut down. But the app, from here, people were told not to use the app anymore, and they used it anyway. So we were monitoring the pandemic for 1 whole year, despite the app not working officially. There was a bunch of people, and there still is, that are, so it's a counterpart. There's a bunch of people that believes in public health and wants to contribute. So I think for any kind of intervention, we have to leverage that goodwill.
Do you think it's possible that the use of the app will like broaden the inequalities in health? Because I mean, if there are a part of people that choose not to use them, and they are the people that are afraid to know that they are sick because they want to go to work, because they don't want to be replaced or something. They are like, they don't want anyone to know that they are sick, or they are afraid of getting sick or getting like problems because of this. And then they choose not to use, or they don't even have the information that this exists or something. And then there is a part of the population that is using it correctly. They can stay at home if they want, and and then they will have even better health and better safety, and other people that don't use will have worse health and worse safety, and it will be like I don't know.
Yeah, I see where you're going. Many people were thinking about this. My perspective is that this is a political choice, in the sense that now in England, for example, you cannot go to your GP, your usual doctor. You cannot go there. Essentially, if you want to get medicines, you have to go to electronic prescriptions and so on. And this whole system has the same problem, because of course, the elderly and people who don't have good access to internet and so on are cut out. Now, the point is that this will be the same for interventions, but the reason to have such an intervention, for example, like electronic prescription, is actually to free more space and time for GPs to look after these people. If at the same time you cut GPs and you reduce their availability and so on, that is a political choice. So actually, the idea is that if you have this kind of contact tracing, then you can free resources for manual contact tracers to focus more on neglected populations, hard to reach populations, and the problem is there. So actually, I think digital tools can actually free resources. But then if you decide to cut the resources instead of using them to reach those populations, that for me becomes a political choice. And the problem, I will not hide it, the problem exists, but it's literally a political one. I mean, these tools can make it better. But of course, if you decide to, but again, if you decide to ignore these populations, the problem is there anyway. And it's, I think it's pretty political. So it doesn't depend on the tool. It depends what you want to. So if these tools allow you for some excess capacity, how you want to use, or if you want just to get rid of this excess capacity.
Connected to this, you have, I think the answer is no, but do you have any information or data regarding the profile, socioeconomic, sociodemographic of the people using the app? So I don't think you have the data, but if you have, do you see any trend of?
So we longitudinal data we should have, but I should dig them out. In general, the profile was quite complicated because essentially there were different groups. So it was heterogeneous, but also quite sparse, because there were different groups that were using the apps for different purposes. And I mean, some purposes that you could not have guessed. So for example, there were, among the young people, there were young people that were using the app because of the QR codes. And young people that were using the app because they wanted to make sure that there wouldn't be another lockdown, because they were feeling so lonely with lockdowns that they wanted to make sure that there were. So surprisingly enough, I was expecting this app to be used more by married people. Comparatively speaking, for example, Internet app was used more by unmarried people because they wanted to avoid lockdowns. Plus, there were groups that were using the app because of trust in the NHS, the elderly that were using the apps for other reasons. So there were different social groups. So it was patchy, but also quite complicated. And again, ethnic groups that were going one way or the other, even similar ethnic groups that for me would be quite similar in many respects. They were, some of them were completely on board with the app, and some of them were not using it.
Do you see any enrichment in the profile of people not using the app?
Yeah, the honest.
Study sociology behind, accepting or not.
So I think so. There is longitudinal data. I don't remember though if there was much about that. Honestly, no, I mean I expect some differences in time, but I don't know if there was actually much about. So one day I would like, the data is still there. One day I would like to dig the data. So there were regular surveys run. And I'm pretty sure that the data is there, but I don't remember if there was any kind of signal in time.
Okay, I'm afraid we have to stop here because the auditorium is booked. So thank you so much.